Um, so Scott, as I was saying, thank you for your work on feedback-informed therapy. Um, do you have a sense of how many therapists seek feedback? How common is it in the psychotherapy industry to seek any kind of feedback?
Depends on who you ask and who is doing the asking. So if you ask therapists, my experience is that most say they are asking for feedback and are feedback sensitive. If you're talking about a practice of asking for feedback using structured measures, I would say the numbers are still very low. There are therapists and clinicians who work inside agencies that have a mandate to measure. And still, even in those instances, most of them aren't using the information that the measures are obtaining.
Mm.
So I would say the numbers are still woefully low. It's a little different in certain spots,
Mm.
as typical of new ideas and innovations in the field, even though these ideas are close to 20 years old now. So, for example, Denmark, Norway, places like that, Germany have a much higher rate of adoption of feedback informed treatment.
Is that because they have state-funded therapy programs?
I think it's because they have single payer systems or something more similar to single payer systems that can and smaller populations, more homogenous populations, and as a result, mandates tend to be taken up. And even there, the practice is still uneven. But if I'm comparing it to the United States, then I would say that it's far and above what's going on here. And I should also mention the UK. The UK also has a been at the forefront of more feedback informed clinical services.
I've sometimes encountered a tendency that if you give negative feedback to a therapist, they make it about you, and that this is reveals something about you rather than about them or the therapy.
Right.
Right? There's a kind
So
of turning it around, flipping it.
yeah, well, and what we say in our trainings is when you're getting feedback, and we like to view it as constructive criticism because it really is an opportunity to make repairs in the alliance between that working alliance between me and the person that is in the room with me that I'm trying to be of help. So I say when you're getting that critical appraisal, you're giving the client's giving you clues about how to relate to them in a more effective manner. That is not the time to turn this into more therapy talk. Oh, the reason you believe this about me is because of something that happened in your life or your situation.
Mm.
Now is not the time to do that. The time is to be very immediate, focus on the feedback that the client is giving you, and talk about what can be done to remedy that. At the same time, I know that some people have talked about feedback informed therapy, often view it as more customer service, like I'm taking a an order at a restaurant. Would you like fries with your therapy? And how about ketchup or mustard? What's your preference? Oh, mayonnaise. Okay, you'd like that instead. That's not what this is about. It really is about closing the gap between the provider of a service and the recipient around the elements that are so crucial to that interaction. Are we working on what you want in a way that makes sense to you, consistent with who you are as a person, your worldview and values? And by the way, what were you hiring me to do in this room? If we can get clarity around that, oftentimes the interaction is much smoother. We know from the data there's also less dropout and the outcomes improve by about 25%.
How common in general is it for psychotherapies to do clinical trials in which they measure adverse events?
I would say more common now as opposed in the past. But interestingly enough, adverse events are what one of the key people I worked with early on in my career was focused on, as was his mentor. So Alan Bergen, who was one of the original authors of the Handbook of Psychotherapy and Behavior Change, the Bible of psychotherapy outcomes, had a student. His name was Mike Lambert. Mike Lambert had a student. His name was Scott Miller. And those folks were really interested in, well, A, what happens when it doesn't work? And by the way, do we harm anybody? So more recently, you're starting to see some interest and focus on adverse events, but still not enough. And I also think in our field that most of these adverse events, they're going to be randomly distributed through the population of clinicians, but they're going to collect, unfortunately, with a handful of clinicians. So they're very personal effects. And that's one of the reasons why we really need to be measuring our outcomes. Not only so I know when what I've done doesn't fit for my client, doesn't help them, and they may be experiencing harm, but also my supervisor might be able to peek in to my data and start to see that, you work really well with this kind of client group, but this client group, you're not very helpful.
So you're saying, I mean, you said in articles about there are super shrinks. Uh,
Hmm.
so you're there also uh, super bad.
Yeah,
You
there are.
and
There are.
and
And yeah, and
what's
I'll
why?
say,
Yeah,
sorry to interrupt you.
yeah.
There's a very interesting, what would you call it, simulation study that was done probably 10 years ago, where they essentially improved outcome by looking at a data pool by removing the worst performing therapists as a group. And that was much more effective than training the therapist, not only in terms of outcome and fewer negative effects, but also in terms of the cost. Really, the kind of continuing education we have and the oversight we have does nothing to address these negative effects from psychotherapy, and it does not improve treatment outcomes.
I mean, I'm sure a lot of my readers are therapists. The last thing they want to be is like a super bad therapist. So,
Yeah.
what are the common mistakes then that are causing harm?
Well, I think that there's a problem in that question. There's there probably are some common things, but these are the same things that are on the other side of the fence. But what are the common things that help clients improve? And the truth is that these common things are not very interesting to therapists, and they don't convey much information. So what's really critical from a feedback informed perspective is measuring you working with this client and getting their input and feedback. Because even if I do what I think is the best therapy that's worked with 10 other people, but it makes this person drop out or feel like I've harmed them, well, does that person not matter? I have to figure out what was it about me, what I was doing, that person at that time, and see, could I have sensed that earlier? Could I have modified what I was doing? And I think the nice thing about FIT is simple tools can help us focus on those clients that we may not be helping and change what we're doing, or in some cases, say, maybe you should see somebody else.
Mm. Before I ask you about those simple tools, one thing that comes up a lot in the psychedelic industry is the uh, resistance to even the terminology of adverse events or harms, because um, the idea is that psychedelic treatments and psychedelic experiences sometimes involve suffering, the worsening of symptoms. And that you need to like accept that and go through it and not frame it as a bad trip or as an adverse event.
Mm,
And I suppose it's the same in psychotherapy. One often hears, you might feel worse before you feel better.
mm,
So, how does the psychotherapeutic industry in general cope with that? The fact that in
mm,
a course of therapy, you can understand someone might feel worse at some point in those, in that process. And to some extent, it is sometimes about trusting the process, even
mm,
if that means it'll show up as adverse events along the way, like they feel more
mm,
anxiety, they feel more bewildered, or something like that.
mm, mm. I would say, and let me see if I can clarify my thinking about this. Some clients are going to worsen during the care that we provide. That's just a given. Saying that, acknowledging that in the context of the relationship, and then saying to them, and that should be expected. That is a therapeutic strategy. The question is, does the client buy it? And do they stick with the process? And in fact, did they get better? So there is no absolute truth in the idea, and I decry this phenomenon where therapists say, "Oh, some clients have to get better." No, they don't. There's no evidence of that.
You
They
mean
don't have to
some clients have to get
have to
worse?
get worse. Yeah,
Yeah.
there's no evidence of that.
Mm.
Uh, None. In fact, the evidence basically says that clients who are worsening continue to worsen and are at much higher risk of dropping out than staying the course and getting better. So again, I view this as a therapeutic gambit or strategy, that statement. Clients are getting worse. I'm not telling them unless I get a sense that that's part of their makeup, part of their theory of change. I'm not going to say, well, hey, this is par for the course. Sometimes you have to get worse. If it is part of the way they think, and I say it and they go, oh, that's good. Oof, I'll stick with it then. Well, then the therapeutic gambit or strategy worked. But if they say, I don't like it and I'm leaving. And by the way, certain therapeutic modalities that approach things in this way, so exposure therapy, for example, have far greater dropout rates than other therapies. Which one is right? Well, the one that keeps your client engaged and moving forward.
Yeah, yeah, that
So
makes sense.
the thing about fit is that it's at each juncture saying, did your strategy engage? Did it help? If it didn't, do you need to rethink it?
Yeah, yeah. Um, you said there's simple tool to seek feedback. How easy is it? I mean, you have designed some kind of simple forms to
Yeah,
gather feedback.
yeah. And I always say when it gets to the discussion of these tools that we developed back in the late 90s, that measurement is the dumbest part of feedback informed work. It's the dumbest part. If measures really helped people, then we just mail everybody in our respective countries a bunch of measures and say, go at it. And then they wouldn't need us. It's really nutty. But what they do is they structure the interaction and they make it harder to ignore the client's feedback. Clients not progressing from session to session, and you can see it. It's hard to equivocate or to reinterpret that data. Well, the client, I'm noticing that the client is getting better in these areas. Yeah, but not in a way that makes a difference to the client. If you want them to stay, maybe it better make a difference for them.
Mm,
So the two measures we developed were one outcome tool or progress tools called the outcome rating scale, and one alliance or relationship measure called the session rating scale. There's nothing magical about our measures compared to somebody else's. They're relatively brief. They've been used all over the place. Lots and lots of not only empirical evidence regarding validity and reliability, but clinical utility as well. And the point is to use them to structure the interaction. When therapists say to me, well, I don't really need the measures, I can ask in my head, I say, do you keep an appointment calendar? I say, of course. Why? Why not just keep your clients in your head? Don't they mean enough to you to just remember all their names and what times you're going to meet them?
mhm.
Physicians use a blood pressure cuff. We should use some kind of tool that's in a structured way that reminds us of what's important. And by the way, I think that's the whole effective feedback.
Mhm.
The whole effective feedback is to know which clients to pay attention to more in the moment.
Mhm. Okay. You gather feedback then. What is deliberate practice? That's looking at where you got weaknesses, where you're scoring lower, and saying, right, I'm going to focus on that and try and
Yeah,
improve. How?
yeah. So it's truly baffling to me that this field of deliberate practice that has been around for 50 years is only in the last 15 years even been entertained by therapists. And there are sort of two schools of thought about it. One is what I believe our field has done for the last 100 years, which is learning and mastering particular models and techniques. And so there are lots of books now about deliberate practice and emotionally focused therapy, deliberate practice and EMDR. And to me, I don't see where using deliberate practice in that way is going to improve our outcomes. It will certainly help us master the particular techniques, but that's not much different from what we've done. When you look at the deliberate practice approach from Anders Ericsson's mindset, it really was about individually figuring out where your weaknesses were and pushing yourself in that particular area. So when you begin to measure, and this is one of the other benefits of measuring, you can start to aggregate your data in time and get a picture of where your weaknesses are and with whom. So maybe your weakness is in how you structure the flow of the session, but that only occurs with clients who are anxious versus depressed, or who are dealing with a traumatic event, as opposed to a run-of-the-mill kind of therapy issue or problem. And early on, we developed a worksheet called the Taxonomy of Deliberate Practice Activities. What we do then is we measure, we identify where our weaknesses are by sorting through our data, and then we map those weaknesses onto factors that have influence on outcome in psychological care, actually in all kind of social care. So those factors that have leverage are things like extra therapeutic events. How well did you leverage the client's family or support system in the care that you're providing? The the therapeutic relationship. How well do you focus on the client's goals? That's just one example of that. Hope and expectancy. How well do you create an expectation of change, particularly when the client is discouraged, and so on? So we measure, we identify our weaknesses, we map those onto factors that have leverage, and then we begin to set some small goals and then develop a plan for remediating those goals or reaching those goals.
We being the therapist and a supervisor or a
Or
coach.
a coach, probably a coach.
So there are coaches who can coach you in kind of deliberate practice around certain therapies and some of these.
Yes.
Yeah.
And what and we in for example in the book Better Results, we talk about the qualities of a good coach. So one of the qualities is that they're an expert in their particular area. Supervision in its history really is about making sure that therapists toe the line, that they're not committing ethical breaches and providing a quality care. But as you know, supervisors vary in terms of their skill set and level, and they're often not experts in the very deficit that you may have.
Yeah.
So I may need to reach out to somebody who is an expert at, well, I was thinking, for example, your particular, the work that you do, psychedelic assisted treatment. That's something I know nothing about.
Mm.
If I were looking for a way to create hope with a client, and it seemed as though they wanted to have mystical experiences or more or reorganizational experiences, I would
Mm.
have to reach out to somebody who knew how to do that.
Hmm.
That's not something that I could provide as a coach. If you're
Mm.
talking about alliance formation, well, then I'm your person. That I know something about.
Okay. Um, so is there what's the evidence base for fit? Has it been tested in clinical trials and so on?
Yeah. So there are now scores of trials and many meta-analyses. And so there's two pieces to this. Overall, the data say that outcomes improve, dropout rates decline, that there seems to be the evidence is a little mixed, but there seems to be some cost savings. And the reason for that is that we're giving more care to the people we're not helping, and we are optimizing the services to the people that we do help. So that's the general picture, but it's really complicated by degree of implementation because most people, when they hear about feedback informed work or what has just been adopted by APA, the American Psychological Association, measurement based care, a very unfortunate term because it plays to the therapist competence rather than to the client's needs. So, who cares if you say, well, do you want your psychologist to measure you? No client cares about that. They want to be helped. So this is some kind of vanity project for psychologists that it just happens to fit what they do. So most people, when they first approach fit, they think of the measures. And as you heard me say, that's the dumbest part of fit. It's not measurement of your blood pressure. It's what the physician or healthcare worker does with that. Their expertise in evaluating, well, are you above or below the mark? Do you need something that will increase your blood pressure or decrease your blood pressure? Or is it something else entirely? Is there some other disease process going on that may account for your blood pressure issue? That's where feedback informed treatment, I think, shines.
Mhm.
Fostering conversations with a healthcare professional who cares about you.
Mm.
In that particular case, what we know is that implementation takes between 2 and 3 years. The pivotal study in this area was done by Heidi Brotland out of Norway in a healthcare system. And what they discovered was that therapists who immediately started getting feedback, number one, they had to start to trust what the data were telling them over their clinical intuition and hunches honed by years of experience. Number two, they had to work systematically to remove barriers in the healthcare system in which they work. Let me give you an example of that. I'm seeing a client, I see them 10 times, I'm not helping. It's clear there's problems in the relationship between me and them. And I say at some point, maybe it's me and you deserve to feel better. Let's see if we can't get you to someone else who might be a better fit or have different ideas. Now, in medicine, this is standard of care. You don't get heart surgery done by your local GP. They refer you to the heart surgeon. But in our field, we don't do that. And there are barriers in place to make that. So a lot of therapists can't say, why don't you go see that person over there? Not only because the system discourages it, but oftentimes there are massive waiting lists for services. So if I'm not seeing them, they may be suffering for a year before they can get in to see somebody else. Now, if the whole system adopted fit, those waiting lists would shrink pretty dramatically. But at the present time, those barriers, I think, make it difficult for clinicians to act on the data that they're getting from their client. And
Mm.
that's why this process takes a bit of time to implement.
So how successful has Fit been in the industry adopting it in different countries and systems?
Again, I think that it varies tremendously. So in in the US, I'd say that adoption really depends on the local leadership and what the in Europe, it's more these single payer systems that have said, we want to measure. So I would say we're in the early stages of if it survives and if it lasts, because there's lots of competing interests. We're in the very early stages. Some people get discouraged by that. They feel like there's active resistance. I don't think there's active resistance. Maybe a little bit. You know, you go into the bathroom, use the facilities, and I watch people leave without washing their hands. How long have we known? Well, Semmelweis was the one who that's almost 200 years ago, and we're still having problems washing our hands. Biggest cause of line infections in the ICU, people not having good hand hygiene 200 years later. So these things take time. And, I have sort of this long view.
But you feel like certain countries like Norway has well, who's been out there kind of the trailblazers?
I think Denmark, Norway, Germany, and then you've got I think a Miranda Woolport, for example, out of the UK. Um, I think are people who really pushed this. So those are countries where I think feedback informed work. Um, I think you're going to find more clinicians, for example, in the UK or in Denmark. If you say, well, do you know what FIT is or feedback informed work or routine outcome monitoring is? More clinicians would say, I at least know what it is than say here in the United States. Here in the United States, if you said to any clinician, do you know what EMDR is? Have you heard of that? Oh, yeah, we know about EMDR. I've been to the 50 levels of training. I am now a fourth degree black belt in EMDR. If you just see more of that here.
Um, Miranda Woolpert talks about the active ingredients of therapy. Is that a concept from this kind of field, or is that something else?
I think that, yes, and I think that's a great term, active ingredients, or what we call therapeutic ingredients, as opposed to particular models and techniques, which are like a total narrative or story about how treatment has to happen that supports a particular therapeutic approach or strategies. So things like extra therapeutic factors, relationship, hope, and expectancy, these are factors that are active in treatment regardless of the particular approach.
Mm. Okay, last two questions.
I'm a big fanboy, by the way, of Miranda Wolford. I think
I,
she's
me too,
one
me too. Yeah,
amazing human being.
yeah, we did some work for her during the pandemic. Um, Me too. I was funded by the Wellcome Trust in my last my last academic job. But
Yeah, she's
so
a person who gets stuff done. Yeah, it's admirable.
so I have to ask, in terms of the UK, we have this national talking therapies kind of program, and I know therapists who work in it, and they I admired it very much when it launched back in 2008. I was helped by CBT myself. But it has also attracted a lot of criticism, partly because of, that it's been somewhat privatized. And so you got therapists kind of, they're having to, the outcome system, which should be a good system that helps patients, actually takes on a life of its own. And so there's a kind of real pressure for therapists to constantly measure outcomes, meet their outcomes. Like loads of the session is then taken up by form filling, and it shifts from actually patient care to meeting targets, as well as various economic pressures and so on, which happen when a system kind of gets privatized. And I suppose that is the concern among therapists, isn't it? Well, I mean, you must have come across that, like where this sounds like even more paperwork. This sounds like bureaucracy. Um, so I suppose it can be done badly, can't it? This kind of
Oh
outcome.
yeah, yeah,
Yeah.
yeah. I think that it can, and our system. I'm always puzzled by it, given the modest impact that therapy has. I'm surprised by how much paperwork it's burdened by, and it's largely, or comparatively speaking, low invasiveness. How come there's so much monitoring going on? I don't really get it. So yeah, I'm not surprised. Now, typically the measurement part of it takes about 30 seconds, one at the beginning, one at the end. Um, and I hear the genuineness in the question. Sometimes in workshops, if people say, "Oh, this just seems like more paperwork," I say, "Can you imagine a physician coming in to the room, picking up their stethoscope and saying, 'Oh, they told me I had to use this thing, so let me stick it on your body. Okay, tick that box.'" You know, there is something that can happen in the process that kills the very spirit of what this is about. That's why in the work that we've done, we talk about the importance of consultation and fit consultation. There's this very specific step-by-step process for reviewing the data and non-progressing cases that's really intended to keep people focused on what this is about, which is are you helping your clients?
Mm.
I think there's another benefit to this. Early on in the super shrink research, we found something I think fairly consistent with research from other areas in the workforce, which was therapists who burned out were much more likely to feel like they had less control over their caseload, which is exactly what you're talking about. Now I'm trying to perform to these standards, and they couldn't get rid of non-progressing cases. So those two things combined led to burnout. Outcome informed therapists in the samples that we looked at had much lower rates of burnout. And one of the reasons for that, we believe, was therapists were immediately given the power to make change. I'm not helping you. Let's do something different. Well, wait a minute. I have not been helping you. Let's get you to something different or decide to end.
Hmm.
That reduces burnout rates.
Mhm.
But making us trained monkeys that we have to meet some certain quota. Well, let me give you one more example. We found early on, which is probably 2003, 2004, that therapists who had lower alliance scores in the beginning that improved had better outcomes at the end across their clients. This is not the way business thinks. Business wants to incent good scores all the time, and people figure that out very quickly. So we have to have a talk with management that the point of fit is to find where there isn't a fit. That's the point of it. We're so that we can cross that divide together with the client. Uh, and if we can get them out of the way of trying to incent certain kinds of scores. Last piece. Most therapists, and this is a standard joke I tell at workshops. I say the worst thing that's going to happen to you when you start measuring your outcomes, I say, is you're going to find out that your mother was wrong about you. You're not special at all. You're just like everybody else. That's the worst thing you're going to find out. The clunkers, the bad therapists are right at the end of the tail, 5 to 13% of the sample. But most of them are either average or slightly above. Okay, so stop worrying about that shit.
Would
Stop
you
worrying about how,
be average or slightly above?
yeah,
Uh,
that well, just by the tail.
if they're okay,
If the outcomes are normally distributed,
yeah,
the 70% of the people are varying right around the average.
right.
And then some are slightly above. And then you've got this small group at the bottom, 5 to 13%, who are kind of psycho-noxious. You know, they just don't help people for whatever reason.
So so some might get the feedback they're in the wrong job.
Some, as 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 would be expected,
Yeah, yeah.
right? And our field probably needs to take those people serious. But when we look at the therapists in our national data, our international database, something like 97% of the outcomes fall between minus zero point 0.3 and plus zero point 0.3 standard deviations around the mean. So it's a very tight distribution. And there are a lot of statistical reasons for that. But it just means that the number of clunkers, it's a small group. It's a problematic group. That's not taken away from it. What is it? Something like 20% of the people fill 80% of prison populations. So it's not a problem that's unimportant, especially when you're their client. But relatively speaking, most people are going to find out, yeah, that they do pretty good.
Last question. What do you think are the potentials or pitfalls of AI for therapy, and particularly around feedback therapy? I can imagine that AI could be a real asset in improving kind of feedback. I read something that someone wrote a couple of days ago about a client who recorded all his therapy sessions and then put them into AI as well and say, help me spot repeated patterns and any biases. And it told him stuff he already knew or the therapist already told him, but there was a few points which, it also spotted. So maybe therapists could use the same kind of thing. Um, so AI in a way gives people an assessment tool for free, right? Video assessment, all these kinds of things. What have you thought about that? Is that something people in your field
Brand
are looking into?
Division 29's journal, which is the Division of Psychotherapy within APA, just had, I think, 2 or 3 articles that were AI related as it relates to deliberate practice. So I think we're on the cusp of something. I'm not an expert in this area. I don't know enough about it. I hear lots of worries about it, but to me, it's the same argument that came up with self-help and with group therapy and with online therapy. To me, access is key. We need people to have access. So the people who will determine whether or not AI helps are the clients. And I can tell you that I know lots of people personally who, once they find out what I do, say, well, I've been talking to chat GPT about my problem. Oh, how is it? I say, oh, unbelievable. Supportive, friendly, always there, can talk to them, whatever, you
Yeah.
know. So to me, the clients will be determining, I think, in
Yeah. Yeah.
part of it.
Yeah.
And
Yeah. That's
and
right.
and I hope that anything that improves access and the potential for this, and again, I don't know enough about it, to help us identify deliberate practice activities and locate weaknesses, you know, I
Yeah.
I I I'm I look forward to that possibility.
Yeah. Okay, Scott. Well, thank you.
My pleasure, man.
Pleasure to talk to you. I'm
Yeah.
going to put this out maybe next week, in my newsletter, which is
Send me a link. Send me a link and I'll blast it out to my group too.
that's awesome. All right, Scott.
Can I ask you just a couple questions?
Yeah, sure.
Tell me about what you think is behind, if there is any such thing,
Uh-huh.
the rise of interest in psychedelics at this time.
I think it's three things. People who feel stuck are hoping for a miracle cure, and this has been touted as the new miracle cure. So people with PTSD, people with, treatment-resistant depression, and anxiety. They just hope, like it's very appealing. The idea in a night you could have a breakthrough.
Hmm.
So that is one of the reasons. Another one is probably the desire for enchantment at the moment. We're in a moment of re-enchantment, more interest in the spiritual and in the mystical. And this again is kind of offering hard-headed rationalists instant enchantment. You
So wonderful.
take part in a mushroom ceremony or go to the jungle and do ayahuasca, or
Yeah.
and it does give you reliably an extraordinary experience. Might be
Yeah.
mystical, might be bizarre, but it's going to be very, probably going to be quite weird and interesting.
Yeah.
Uh, and then there's also just the kind of the hype machine. It's been massively hyped by
Yeah.
the media, by documentaries like Netflix. Michael Pollan's book had a huge impact. And it has all the credibility of all these universities working on it. It's just about to be FDA approved. So that's just created this big hype machine,
Hmm.
a lot of which has then, gone into the ketamine industry, which
Hmm.
actually in some ways has more risks than other types of psychedelics of dependency. So
Hmm.
that's become a big thing. And it's not really a psychedelic, it's kind of a dissociative.
Yeah.
That's become a huge industry.
Yeah.
Um, but it's just, yeah, I mean, I think in some ways, even though it's presented as spiritual and mystical, it also appeals to our kind of materialist culture. Like, oh, I'll take this substance and that will just boost me forward, as opposed to like maybe, therapy, just talking about my problems for
Or
weeks,
church or
or yeah, or church, yeah. So, but it's still kind of relatively marginal. I mean, we're talking about. Um, it's gone from about 2.5% of adults take magic mushrooms in any year to about 5%. So,
hmm.
it's been very amplified by the media, but we're not
Hmm.
talking like
Huge
40%,
numbers.
60.
Yeah. Yeah.
Yeah.
Yeah.
It's just
Yeah.
it has gone up, but from quite a small figure.
And is there something that you're seeing in the culture, development culture that is contributing to this desire for enchantment or re-enchantment? Is there
In psychedelic culture?
in either psychedelic culture, just in general Western culture that
Um, well, why is it happening? I mean,
so we did a paper and then I did several presentations at the last Evolution conference on it was called How Psychotherapy Lost Its Magic.
hmm,
And I'll send you a copy if you're interested. You don't feel obliged. But in there, this is what we talked about.
mhm.
This whole desire for enchantment and how psychotherapy, in the name of science, has wrung out anything interesting, anything human, anything beyond human, that we are just these people trapped on this little gaseous planet, and then you die at the end of it, and it means nothing.
Mhm.
There is there, so we were writing about that as well. We got distracted by the deliberate practice research. So, but I have a similar sense about this.
Mhm.
Uh,
I mean, I wrote a book called The Art of Losing Control, just saying, look, people have these experiences which are called like mystical or self-transcendent, or spiritual experiences, ecstatic experiences. And on the whole, psychotherapy didn't find a place for them. And
yeah,
academia didn't really find a place for them. And secular progressive culture didn't really find a place for them. But people still have them. And
yeah,
people are still curious about them.
yeah,
And you know, there have been times in therapy where there was a bit more of a space for them, and there have been particular therapists, William James, Maslow. The
yeah,
60s was much more like Gestalt and others,
yeah, yeah.
and some of that has kind of come back, and it's also like the rise of wellness, the rise of alternative health, and the rise of alternative media.
Hmm,
So, in wellness and alternative health, ecstatic experiences have much more of a place,
hmm,
along with things like ceremony and so on.
hmm,
Uh, and psychedelics are very much part of that boom in wellness. I mean, like we've now got a secretary of wellness,
hmm,
in RFK. I mean, he's basically a wellness
hmm,
guru,
hmm,
isn't
hmm.
he?
Yeah,
He's undermining various forms of established science and promoting
hmm,
various forms of wellness like
yeah,
psychedelics.
yeah,
And you have alternative media massively rising, like Joe Rogan is the most popular podcast, endless podcasts about DMT or UFOs or this or that,
yeah,
fringe ecstatic kind of beliefs.
yeah,
So all of that, the kind of the secular liberal mainstream is very shaking, and the alternative is rising, and with that comes the rise of interest in the ecstatic and the
yeah,
transcendent.
yeah,
And the role of religion in the US is quite complicated. I mean, but people are leaving churches and becoming
yeah,
spiritual but not religious and getting into
yeah,
things like occultism and so on. And
yeah.
psychedelics is just very reliable and monetizable, and
Hmm,
commodifiable. You
hmm,
buy this and you take it, you are going to have some kind of experience,
hmm.
you
Yeah,
know.
that's
uh,
a guarantee.
yeah, that is a guarantee. So, so yeah, so I think that,
Interesting.
but it's been overpackaged. I mean, there's I wrote a book in 2017 saying we should find space for ecstatic experiences. They're important, they're normal, they're human. But now it's like you see how commodified it is,
Yeah, yeah.
on
What happens
Instagram
to
and
everything?
so on,
Yeah,
and like the retreat space is, it's so narcissistic,
yeah,
and it's irresponsibly promoted, and it can be culty and all these, and just kind of high on certainty and
yeah,
ignorant certainty, and like I said, complete lack of responsible gathering of feedback.
yeah.
So you see that a lot in the underground space, like I'm a psychedelic shaman after, like, one ceremony or after a weekend course. I'm a healer, I'm guided. Their client then contacts them saying, look, I feel worse, I feel destabilized. They get ghosted, or they get told something like, you're not listening to the medicine. So the ethics, I mean, and I talk about, like, it's ethical if you're a healer to try and do no harm and try to check that you're doing no
Yeah,
harm. Don't rely
yeah,
on your intuition. But in wellness
yeah,
culture, psychedelic culture, it's very people who are very high on intuition. It's all like, I feel called, the plants tell me.
yeah,
Yeah. So
yeah. And then I promise I'll let you go. Have you encountered Ian McGilchrist's work?
yeah, yeah.
Yeah,
I know him. I've read his book. I mean, I'm from the UK, so yeah, very popular. And like the interesting side of it is, trying to balance the rational and the mystical.
yeah,
Is what he's trying to do, and say, oh, your left brain is rational and your right brain is
yeah,
mystical. And it
yeah,
very much appeals to people who are trying to find that balance in themselves,
yeah,
who are
yeah,
maybe very rationalist people, but they have a mystical side.
yeah,
Um, you know, it's also kind of grand history,
yeah,
which
yeah.
is
Absolutely.
somewhat unfalsifiable. So
Yeah, yeah,
yeah,
exactly. Yeah, no, it explains everything, all of Western civilization.
yeah, like, and exactly, our hemispheric changes explains the history of like, well, it could be, like, how you gonna test that? Same with Julian Jaynes, if you ever read him back in the day.
Yeah,
But
yeah.
yeah, like there's something in our culture we are trying to uh integrate different aspects and
Mm,
trying to, I mean, my newsletter is called Ecstatic Integration, so
mm,
reintegrating ecstatic experiences. But how we do that whilst not ditching evidence and discrimination and ethics and safeguards is
mm,
the challenge.
yeah.
And it's a hard one, but
Mm,
the kind of feedback you're talking about, I would love to see psychedelic retreats doing. They get
mm,
people week in, week out coming, getting blasted into the stratosphere,
yeah.
and a lot of them feel a lot better afterwards, sometimes miraculously so,
Mm,
saved from suicidal ideation, say, or that kind of
mm,
thing, but
mm,
not all of them. And
yeah,
there's very little measuring of outcomes.
yeah.
Um, there are now kind of there are, so this is the bee in my body.
Mission.
Yeah,
Yeah,
trying
yeah.
to
That's
improve the
good.
measurement of outcomes and
That's
particularly
good.
of harms in that space.
I'll be interested to hear what kind of reaction you get from it. Um, uh, when we started studying super shrinks, the reason we did this was because we had no idea really about deliberate practice. It was a front door to this whole concept of how do they get better. And a very well-known researcher from the UK told me, you can't write about these super shrinks. The clinicians are all tired and overworked, and they don't want to hear this. And I thought, geez, they don't want to know how to get better. They don't want to know if they got better that they wouldn't feel the way they feel. It's like mind-boggling. I also have people who say, I don't really need to ask formally for feedback. One guy told me I've remembered this to this day, it's probably 10 years ago, unconditional empathic reception he had. And I thought, what the fuck is that? How do you get it? This work is hard. So it'll be interesting to hear from this community. I suspect it won't be much different from the current community, and that structural barriers or the lack of them may impede people's interest or willingness to ask for feedback.
Well, it's, there's, like you say, kind of exhausted clinicians, and there's, certainly there's a lot of that in the UK, but in the underground, yeah, and that could be true in retreat centers, by the way. They tend to be overstretched. So they
Hmm.
have overstretched, unprofessional systems which cause harm and
Yeah,
burnout in the people working there.
yeah.
And how do you get already overstretched systems to try and improve? And they don't have they're
They
already
don't
over.
have a system for that in place.
And
Yeah.
I know companies trying to help them by providing, say, look, let us do some of this stuff. Let
Hmm.
us let us take care of, the screening. Let us take care of maybe feedback as well. And let us present to you kind of monthly. But and then there's people who just just trust their intuition. And I think there's a, or they're a bit narcissistic.
Hmm.
And they don't want to, they're just high on being a healer,
Yeah.
on being the magic healer.
Yeah.
And so someone being harmed is a kind of doesn't fit their glowing
Right.
self-image.
Yeah.
But then there are plenty. I mean, the ones who read my newsletter, and I'm doing stories of harm quite often. So they're subscribing and reading because they don't want to cause harm. So
Yeah.
you
Fantastic.
have a main group, I would say, who are
Hmm.
trying to
Yeah.
not cause harm.
Yeah.
So yeah, but it's a combination of appealing to individuals not wanting to cause harm and then thinking about systems that can be put in place
Yeah.
to track
Absolutely.
outcomes. Yeah,
Good, man. Good luck to you. And if I can do anything to help, let me know. And I'd love to get a link when it goes up,
I
and I'll
will
blast
do.
it out to my group.
Thank you so much, Scott. All right,
Okay.
take care. Bye.
Bye.